I am Ziad Ghazal for the Division of Cardiology. Happy to be with you again. In the first lecture I gave on congestive heart failure, the main points that I stressed were related to the pathophysiology of congestive heart failure. Today we will talk about the clinical presentations of patients with congestive heart failure and how to manage them. And then the last section will be on cardiogenic shock. Let's start by reviewing one more time possible causes of heart failure. Chronic hypertension is a common cause, especially if left untreated. Other causes are obstructive cardiomyopathy, such as HOCM, the hypertrophic obstructive cardiomyopathy. Dilated cardiomyopathies, we will discuss these in the lecture on cardiomyopathy. Ischemic heart disease is a very important cause. Patients can present with unstable angina or acute coronary syndrome in the form of non-ST elevation myocardial infarction or a full-blown ST elevation myocardial infarction causing a reduction in ejection fraction. Other causes of heart failure include infiltrative disease such as sarcoidosis, amyloidosis, and hemochromatosis. Structural abnormalities such as valvular heart disease. Patients can present, for example, with wide open aortic regurgitation or severe aortic stenosis or severe mitral regurgitations and other form of valvular disease. They can present with ventricular septal defects. Patients can also have an infectious etiology, such as viral myocarditis. Congenital heart disease certainly can lead to heart failure in a number of situations. And chemotherapeutic drugs can also cause or lead to heart failures, and there are also a long list of etiologies. So what are the heart failure symptoms to look for? Typically, patients present with dyspnea and orthopnea, and they often complain of reduced exercise tolerance. They will tell you that I used to go up 3 flights of stairs, for example, without much difficulty, but now I slow down after I get to the 2nd flight of stairs because I get short of breath. People can present with paroxysmal nocturnal dyspnea. They will tell you that while I'm fast asleep at night, I have to all of a sudden get up because I'm short of breath, and I have to sit up to the side of the bed to take a deep breath. Patient can also present with peripheral edema, typically ankle swelling. Other symptoms are less typical or less specific, such as cough that can present with patients in pulmonary edema. They could have dyspnea and cough. They can have abdominal distension, specifically if they have ascites. A non-specific symptom is fatigue that the patients can report. They can also have palpitations, especially if they have some significant arrhythmias. Sometimes, for example, atrial fibrillation or atrial flutter, or even short non-sustained ventricular tachycardia. Patients in heart failure can present with weight gain, especially early on before being treated with diuretic therapy as they gain fluids. But on the long run, they can go in the opposite direction and become cachectic, what we refer to as cardiac cachexia. Now, there is a classic classification of heart failure symptoms, referred to as the New York Heart Association classification that you need to remember, also referred to as the NIHA classification. Class 1 NIHA classification is when patients with heart disease without resulting limitation of physical activity. On ordinary physical activity, they do not have heart failure symptoms such as fatigue or dyspnea. When they're in class 2, patients with heart disease have slight limitation of physical activity and the symptoms of heart failure develop with ordinary activity, but there are no symptoms at rest. Class 3, patients with heart disease present with marked limitation of physical activity. Symptoms of heart failure develop with less than ordinary physical activity, but there are no symptoms at rest. And NIHA class 4 is when patients with heart disease present with inability to carry on any physical activity without discomfort, and symptoms of heart failure may occur even at rest. Now let's turn to the physical examination. Of course, a number of findings could be evident, and at times many of what you see on this list could be part of the presentation, and at other times the findings are very scant when the presentation of heart failure is not typical. So patients could present with cool and or mottled extremities. Typically early on they can be tachycardic. When the heart failure is advanced, they could be hypotensive with a narrow pulse pressure. In case of congestion, and especially when there is right ventricular failure that could be primary, or as a result of left ventricular failure, patients could present with elevated jugular venous pressure. The point of maximum impulse when you palpate the chest could indicate left ventricular enlargement if the PMI is laterally displaced. You could have a number of cardiac murmurs depending on the etiology of the heart failure if it is related to valvular heart disease. Typically, there is what is referred to as an S3 gallop. On lung examinations, you will hear crackles, specifically at the lung basis, or decreased breath sounds if you have significant pleural effusions. In some patients, especially when you have right heart failure, they could present with ascites and hepatomegaly, and you could test for hepatojugular reflux. And of course, many patients will have lower extremity edema. Now, remember that heart failure could be predominantly left heart failure, or it could be predominantly right heart failure, or both. In case when the presentation is predominantly left heart failure, patient is typically tachypneic, reports orthopnea, and has pulmonary edema on physical examination with bibasilar crackles on lung auscultation. When the presentation is predominantly right heart failure, patient typically has distended neck veins and hepatic congestion. There is a good possibility to find ascites and, of course, peripheral edema. Tachycardia, gallop rhythm, and a narrow pulse pressure is typically common to both left and right heart failure. And patients may present with hypotension. And of course, they could also have a murmur, as we indicated before, that is associated with valvular heart disease as an etiology of the heart failure presentation. So now, what is our initial approach to a patient with suspected or diagnosed heart failure? First, in terms of clinical history and physical examination, it is very important to go over the symptoms and signs that we elaborated on before. And then once we suspect or make the diagnosis, then we need more tests such as an electrocardiogram, a chest X-ray, blood labs, specifically BNP, beta natriuretic peptide, usually a complete blood count, metabolic profile, and specifically look at renal function and electrolytes, liver function test, thyroid stimulating hormones, since the thyroid could also be part of the etiology of the heart failure, lipid profile, and some other blood tests. An echocardiogram is always very important, as we detailed in the first presentation, to determine many things, the ejection fraction, the state of the valves, whether or not there is diastolic dysfunction, whether or not there is left ventricular hypertrophy, if there is pericardial effusion, if there is constrictive pericarditis, and so on and so forth. The echo is a very, very valuable tool in the diagnosis and management of heart failure, but it is beyond the scope of this lecture to expand on the findings of an echocardiogram in such situations. And of course, as part of our clinical assessment, we need to assess the volume status, and very important, as I indicated before, to evaluate and follow and monitor the renal function. Then, after obtaining all this information, we need to classify the category of heart failure according to the ejection fraction, as we mentioned in the first lecture, and try to differentiate between heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction, so HFrEF versus HFpEF. And of course, try after all of this to determine the cause and the precipitating factors. Then we initiate treatment for acute decompensation, and while we do this, we monitor for hemodynamics, heart rate and blood pressure, and oxygen saturation. We monitor for any rhythm disturbance. Patient could have concomitant atrial fibrillation. They could be in sinus tachycardia. They could have bradyarrhythmic events during the course of treatment. They could have a number of ventricular arrhythmias, including sustained and non-sustained ventricular tachycardia. And we monitor the labs, specifically the renal function, electrolytes, as we give diuretic therapy, for example, and a number of other laboratory values. And of course, we always have to apply, once we get the patient out of the acute cardiac decompensation, apply guideline-directed medical therapy for chronic heart failure, which I will be elaborating on. So now let's turn to the pharmacologic treatment. But I should indicate to you that I will give you only a brief overview, since you are getting more details in the pharmacology lectures. Before diving into the pharmacology, I will start by reminding you about the importance of the neural hormonal activation compensatory mechanisms that are constantly on in heart failure, and that I alluded to in my first presentation. These systems try to compensate for the failing heart's inability to maintain normal cardiovascular balance, And the chronic presence of these neurohormones potentiates the hemodynamic abnormalities present in heart failure, which promote further remodeling and neurohormone release and further hemodynamic deterioration. Therefore, the best way to understand the pharmacologic approach to heart failure is to tie it to the pathophysiology that we discussed earlier related to those neurohormonal compensatory mechanisms. Now remember that there is a purely beneficial compensatory mechanism, which is the natriuretic peptide system. It causes vasodilation, and it reduces actually aldosterone. It reduces systemic vascular resistance, reduces sympathetic tone, and it has it slows down cardiac fibrosis and cardiac hypertrophy. It also increases natriuresis and diuresis, and this all leads to a reduced cardiac workload. Now, it's important to remember that these natriuretic peptides are beneficial, and they are important in the physiologic response to heart failure. Neprilysin is a metallopeptidase which catalyzes the degradation of natriuretic peptide. So in order to reduce that degradation, there is a drug that inhibits the neprilysin enzyme, which breaks down beta-natriuretic peptide, and it's called the angiotensin receptor neprilysin inhibitor, or ARNI, A-R-N-Y. So ARNI is very important. It's a very important medication that counteracts the effect of neprilysin, which degrades the natriuretic peptide. So that's one important drug in our armamentarium in the treatment of heart failure, and I will come back to that a little bit later. So as I indicated, ARNI works by simultaneously inhibiting neprilysin and blocking the angiotensin II type 1 receptor. Therefore, it results in vasodilation, natriuresis, and diuresis, which are all favorable effects in heart failure. ARNI is important in the management of heart failure and has been shown to even reduce mortality in clinical trial. Now let's turn to the compensatory mechanism in heart failure, which ultimately are detrimental. One is the renin-angiotensin-aldosterone system, which can also cause vasoconstriction. It causes a increase in aldosterone, increase in systemic vascular resistance, in sympathetic tone, and it promotes cardiac fibrosis and cardiac hypertrophy. The final outcome is sodium and water retention. This system can be counteracted through several pharmacologic approaches. The angiotensin converting enzyme inhibitors, such as ramipril or lisinopril, have also been shown to be beneficial even in terms of mortality reduction in clinical trials. In a small percentage of cases, ACE inhibitors can cause a persistent cough, which normally is not caused by angiotensin receptor blockers such as losartan or condesartan. ACE inhibitors and angiotensin receptor blockers should not be prescribed without verifying a normal serum potassium and adequate renal function. They are contraindicated with a history of angioedema or bilateral renal artery stenosis. Then there are the mineralocorticoid receptor antagonists or aldosterone antagonists, such as spironolactone or eplerenone. They can also be used in heart failure to counteract the renin-angiotensin-aldosterone system. They work by increasing sodium excretion via diuresis and ultimately decreasing cardiac workload. The other important pathophysiologic response is the sympathetic nervous system with the release of catecholamines, namely epinephrine and norepinephrine, mediated through alpha-1 and beta-1 and beta-2 receptors. The effect of catecholamines release include vasoconstriction. These can be counteracted using beta blockers, which have been proven to be beneficial in clinical trials. Beta blockers such as bisoprolol, metoprolol, or atenolol decrease heart rate, myocardial oxygen demand, and blood pressure and heart rate, of course, need to be monitored carefully when adjusting beta blocker doses. They are contraindicated in asthma and certain Brady arrhythmias. So on this slide, you see the response to heart failure in terms of physiologic and pathophysiologic, the mechanism of actions and receptors, and the medications that are used to counteract the negative effect of the hormones, of the neurohormones, in order to help manage the patient with heart failure. Now let's turn to the classification of acute heart failure when we evaluate a patient in the emergency department or in the coronary care unit. First, we perform a clinical evaluation of signs and symptoms and determine if the patient is what we refer to as wet or what we refer to as dry. Wet is derived from signs and symptoms of congestion. This occurs when there is a high pulmonary capillary wedge pressure, usually estimated at more than 22 millimeters of mercury. Of course, we don't always measure the pulmonary capillary wedge pressure since this would require an invasive catheter for measurement, but in general, the pulmonary capillary wedge pressure would be elevated when the patient presents with dyspnea and have bibasal crackles on physical examination, meaning pulmonary edema, and may also be orthopneic and have elevated jugular venous pulsation and peripheral edema. On the other hand, the patient may be quote unquote cold, meaning that the patient has signs and symptoms of low peripheral perfusion and low cardiac output manifested by cold extremities, oliguria, and narrow pulse pressure. So now that we understand the difference between wet and warm and cold and dry, there are four possible combinations to these clinical presentations. One is a patient who presents with signs and symptoms indicating dry and warm, meaning that the patient is adequately perfused and hemodynamically compensated. This would be the best scenario, and all that the patient requires is optimization of oral therapy in general. Now, a second scenario is when the patient is assessed as presenting dry and cold, meaning that the patient is euvolemic, but possibly hypovolemic, where you would consider some fluid challenge. But at the same time, the patient is cold, meaning has a low cardiac output, and you would consider inotropic agent if still hypoperfused. A third case scenario is when the patient presents as wet and warm. This is when the patient is congested but well perfused. If the patient's blood pressure is elevated, you could benefit from optimizing vasodilator therapy, such as the ACE inhibitors or angiotensin receptor blockers, and you could also use diuretics since the patient is congested. But if pulmonary congestion is the main presentation, then you would primarily rely on diuretic therapy followed by vasodilators. The final case scenario is when the patient is wet and cold, meaning congested and hypoperfused. In this case, if the systolic pressure is less than 90 millimeter of mercury, then you would start with an inotropic agent such as dobutamine and possibly a vasopressor if the blood pressure is still low, such as norepinephrine. Then you would add a diuretic therapy if the blood pressure allows. So once you start restoring the blood pressure to higher levels. And on the other hand, if the blood pressure to begin with is more than 90 millimeter of mercury in this wet, cold presentation, you would start with a vasodilator therapy and diuretics, and you would resort to inotropes in refractory cases. So I think this is sort of an important classification of that you would try to use in patients presenting with acute heart failure, because it will help you put them on a better management course. So now let's sum up the categories of drugs that are used in the management of chronic heart failure. First and foremost, diuretics are used to relieve congestion and achieve euvolemia. Diuresis, such as with furosemide or bumetadine, work by increasing sodium excretion via diuresis, ultimately reducing cardiac afterload. An afterload reducer is essential, and this typically comes in the form of an angiotensin converting enzyme inhibitor or ACE inhibitor, or an angiotensin receptor blocker, referred to as ARB. But then it is preferable to ultimately switch to ARNI. Remember the medication that we discussed before, which while closely monitoring the blood pressure. Hydralazine can also be used for vasodilation, but it is not a first-line therapy. Beta blockers are part of the armamentarium as well. Of course, we should not use beta blocker if the patient is in acute heart failure. We should first get them somewhat out of acute heart failure and then slowly initiate beta blocker. So in chronic heart failure, beta blockers help reduce the stress on the heart by inhibiting the sympathetic activity, as we mentioned. And then another potential medication is mineralocorticoid antagonists, such as spironolactone or eplerenone that we mentioned before. It can also be added, and ultimately there is the SGLT2 inhibitors. SGLT2 inhibitors, also called sodium glucose cotransporter 2 inhibitors, they have been shown in randomized clinical trials to decrease the risk of major cardiovascular events in patients with heart failure and diabetes. But some specific SGLT2 inhibitors can also decrease major cardiovascular events in patients with heart failure, even without the presence of diabetes. SGLT2 inhibitors have a mild diuretic effect and decrease sodium, which results in a decrease in plasma volume and blood pressure. The reduced circulating volume decreases preload, and afterload is also decreased with the lower blood pressure, and improvement of cardiac blood flow. Therefore, these class of drugs have been added to the management of patients with chronic heart failure. Patients with heart failure are also evaluated for the need of digoxin. The typical indication for digoxin is congestive heart failure with a presentation or a concomitant presentation of atrial fibrillation and a rapid ventricular response. Since digoxin or lanoxin has a negative chronotropic response without the negative inotropy seen with beta blockers. And a last medication that I want to discuss with you is very briefly is, and that's to consider in patients with heart failure who are still tachycardic despite using a beta blocker. That medication is ivabradine. Ivabradine reduces the firing rate of the pacemaker cells in the sinoatrial node without affecting the duration of the action potential and has no negative inotropic effect. Therefore, ivabradine can be added to a beta blocker if the heart rate is still above 70 per minute. Ivabradine can then be added in small doses and titrated, up-titrated accordingly. Once you have made a diagnosis of heart failure and started the patient on the proper management strategy, it is important to avoid heart failure exacerbations. Here is a list from up to date that reminds us of factors that could contribute to exacerbation or worsening heart failure. There are some cardiovascular factors, as you see on this list, such as when there is superimposition coronary ischemia or myocardial infarction in a patient already with the diagnosis of chronic heart failure. Also, if the patient blood pressure becomes uncontrolled, then this could certainly potentiate or exacerbate heart failure. Sometimes you have unrecognized primary valvular disease that could contribute to the diagnosis or exacerbate heart failure. You could have worsening secondary mitral regurgitation, which we refer to as functional mitral regurgitation. That's when the ventricle, left ventricle has dilated and the mitral annulus has dilated, causing secondary mitral regurgitation. As we mentioned earlier, patients with heart failure could present with either or could have an exacerbation with a new onset presentation of atrial fibrillation or when the atrial fibrillation that may already exist presents in an uncontrolled manner with a fast ventricular response. So that could certainly potentiate or could contribute to worsening heart failure. If the patient is excessively tachycardic, that could be a reason of exacerbation. If a patient presents with another problem, such as pulmonary embolism, that certainly adds oil to fire. There are some systemic factors that need to be considered. We always need to review the patient's medications, as sometimes we see some inappropriate medications being prescribed. Sometimes we face superimposed infection in a patient with already a chronic heart failure, anemia from other causes, uncontrolled diabetes, thyroid dysfunctions, are diseases that we need to also pay attention to. There are some patient-related factors such as medication non-compliance. Remember that medication non-compliance is a major reason for, and even a dietary indiscretion are major reasons for worsening heart failure or what we refer to as heart failure exacerbations. Alcohol consumption is certainly a definitive reason, and also substance abuse. Now let's turn to the clinical presentation of shock. Remember that shock could take different forms. One is hypovolemic shock, when patients present with massive blood loss or GI losses, including diarrhea and vomiting, burns with severe third spacing. These are all causes of hypovolemic shock. Cardiogenic shock, on the other hand, could present when patient has a large myocardial infarction, such as with occluding a proximal large left anterior descending artery. They could present with severe valvular disease, such as with the other day we received a patient with endocarditis that has eaten up the aortic valve leaflets, and the patient presented with severe aortic regurgitation and cardiogenic shock. Arrhythmias, incessant ventricular tachycardia could be a reason, or could be concomitant with cardiogenic shock. Fulminant myocarditis is certainly a rare but important reason for cardiogenic shock, and there are multiple other reasons of cardiogenic shock, including a ruptured ventricular septum that could even be a complication of a advanced myocardial infarction. Then there is the obstructive kind of shock. Examples are a large pulmonary embolus, bad pulmonary hypertension, significant cardiac tamponade causing hemodynamic compromise. Constrictive pericarditis is another example, and one more example under that category would be tension pneumothorax. And then there is the distributive kind or form of shock, such as what you see in anaphylaxis, or in septic shock, or in neurogenic shock, or in toxic shock, or situations such as when you have pancreatitis, and any situation that causes severe third spacing. When should you suspect shock? Obviously, by definition, patient would be hypotensive. Typically, the patient would be tachycardic. The urine output would be low. Many patients would also have an abnormal mental status, would be tachypneic. The extremities typically are cool and clammy, and also metabolically the patient would be most of the time in metabolic acidosis. Now let's turn specifically to cardiogenic shock. This is the definition from the famous shock trial that has been conducted several years ago. Patient would present with persistent hypotension with a systolic blood pressure of less than 90 millimeter of mercury, or a mean arterial pressure of 30 millimeter of mercury below baseline. Typically, the cardiac index would be less than 1.8 liters per minute per meter square without support, or less than 2.2 liters per minute per meter square with support. And patient would have an adequate or even elevated filling pressure, where the left ventricular end diastolic pressure would be more than 18 millimeter of mercury, and the right ventricular end diastolic pressure more than 10 millimeters of mercury. If the filling pressures are low, it would make you think more of hypovolemic shock rather than cardiogenic shock, for example. The best way to also understand shock is to understand the stages of cardiogenic shock. As as adapted from the Society of Cardiovascular Angiography and Interventions from their expert consensus statement. Starting from below, that's an A, B, C, D, E classification. A, at the bottom of the slide, is referred to as at risk, a patient with risk factors for cardiogenic shock who is not currently experiencing signs or symptoms. For example, the patient is presenting with a large acute myocardial infarction or had a prior infarction or had acute and or acute on chronic heart failure, but is not currently experiencing signs or symptoms. So, but that patient would be at risk of developing full-blown cardiogenic shock. B is for beginning, when a patient who has clinical evidence of relative hypotension or tachycardia without hypoperfusion. C is for classic, when a patient presents with hypoperfusion requiring intervention beyond volume resuscitation, such as the need of an inotrope or pressor or mechanical support. These patients typically present with relative hypotension. D is for deteriorating, when the patient who fails to respond to initial intervention. That's similar to stage 3, but is gradually getting worse. And E is for extremis, when a patient being supported by multiple interventions who may be experiencing cardiac arrest with ongoing CPR and or extracorporeal membrane oxygenator, which is a mechanical circulatory device that supports patients with cardiogenic shock. Now let's turn to some selected inotropes and vasopressors used in cardiogenic shock. I will not give you too much detail since you will be getting the necessary details from the pharmacology lectures. Dobutamine. Dobutamine acts primarily on beta-1 adrenergic receptors. It has a minimal effect on beta-2 and alpha-1 receptor. Dobutamine's hemodynamic effect include an increase in stroke volume and cardiac output, and has a modest and causes a modest decrease in systemic vascular resistance and pulmonary capillary wedge pressure. Dopamine, on the other hand, works slightly differently. At low doses, dopamine acts primarily on what we refer to as the dopaminergic receptors, which serve to dilate the arteries of the renal and mesenteric beds. At medium range dose, such as 3 to 10 mic per kilo per minute, dopamine also stimulates the beta-1 adrenergic receptors and increase cardiac output, predominantly by increasing stroke volume, and it has a variable effect on heart rate. And at medium to high doses, dopamine also stimulates alpha adrenergic receptors. Norepinephrine stimulates alpha-1 and alpha-2 receptors to cause vasoconstriction. It is really the initial vasopressor by excellence. It is the initial vasopressor of choice in septic, cardiogenic, and hypovolemic shock. Finally, I want to briefly discuss with you milrinone, which is a phosphodiesterase inhibitor that increases myocardial inotropy by inhibiting degradation of cyclic adenosine monophosphate. Milrinone is also a potent arterial and venous dilator. Remember that it does inhibit vascular smooth muscle phosphodiesterase, and that leads to a reduction in systemic and pulmonary vascular resistance, and also a reduction in right and left heart filling pressure. So basically, all these effects result in an increase in cardiac index and a decrease in left ventricular afterload and filling pressures, which are all beneficial. And finally, closing on this subject of cardiogenic shock, remember that in cases of advanced heart failure, part of the early workup is evaluating coronary revascularization when ischemic heart disease is suspected, and also evaluating, as we indicated before, for valvular etiologies that could require valve surgery or repair, either surgically or percutaneously. This is, of course, when we document valve disease contributing to heart failure. And consideration for cardiac resynchronization therapy is beyond the scope of this presentation, but very briefly, cardiac resynchronization therapy involves implantation of pacing leads to the right and left ventricles via the coronary sinus, which are timed to send pacing signals at a specific preset interval to maximize synchrony between the ventricles. The largest benefit from CRT or cardiac resynchronization therapy is in patients with a wide QRS complex, usually more than 150 milliseconds, with left bundle branch block morphology and while in normal sinus rhythm. Then there are indications in patients with heart failure and reduced ejection fraction for an ICD, which is an implantable cardioverter defibrillator. That's because sudden cardiac death being a leading cause of death in patients with heart failure with reduced ejection fraction or HFrEF. Some may be eligible, specifically those with an ejection fraction of 30% or below, but the cutoff line we start considering at 35% or below. Those patients are considered for the implantable cardioverter defibrillator to reduce the risk of sudden death. There is also the timely referral of select patients to a heart failure specialist when, especially prior to the onset of multi-organ failure, so that those patients with advanced disease can be considered for mechanical circulatory support, such as, or namely, the left ventricular assist device, or even heart transplantations, which is offered in advanced centers in the world. So with this, I'm concluding this talk on the presentation of management of patients in congestive heart failure, both in what relates to an acute decompensated heart failure presentation or chronic heart failure, and how to deal with in patients with cardiogenic shock, how to recognize patients in cardiogenic shock, and how to offer management to those patients. And finally, I covered for you just a very, very brief highlight of how to deal with patients in advanced heart failure. Thank you.